To the prestigious 15th Professor Mehra Oration, I would like to request Dr. Priyanka to welcome and hand over bouquet to Lieutenant General Dr. Ajith Nilakantan, Commandant and Director, Army Hospital Research and Referral, New Delhi, who has graciously agreed to deliver talk for the prestigious Professor Mehra Oration. Welcome, sir. Now I would like to request Dr. Parul to present bouquet to Professor R.K. Rathore, our Sub-Dean Research. Welcome, sir. Now I would like to request Dr. Naresh K. Panda, Professor and Head of the Department of Otolaryngology, Aortic Surgery and Dean Academic, to deliver the welcome address. Sir.
Good afternoon. Lieutenant General Ajith Nilakantan, the orator for today's evening, Professor R.K. Rathore, Sub-Dean Research, Madam Mehra, Mrs. K.S. Chugh, Mrs. Urvashi Gulati, former Chief Secretary, Government of Haryana, Professor G.D. Puri, former Dean, Madam Suri, former Dean, Professor R.K. Suri, former HOD of Cardiovascular Surgery, former heads of departments, faculty members, and dear students. It gives me great pleasure to welcome Lieutenant General, I would add Dr. Ajith Nilakantan, who, in spite of having a simple demeanor, has risen to the highest position of a doctor can aspire. He is the director and commandant of the Army Hospital, which is also called as Research and Referral. Not only he is proved to be a good clinician, a competent surgeon, a great administrator, he has another feather to his cap, and that is he's very much interested in literature. In fact, last year when I happened to meet one of his classmates who talked, just matter of fact, we were talking about our days when he said, about Ajith. And then he said that when they were in school, the English teacher was always very much scared to give less marks to Ajith, lest, he would, object because, he would score 9 out of 10 in an essay competition. So that's another, um, quality Dr. Ajith has. So welcome, Dr. Ajith. Really grateful to you to have accepted our invitation readily to deliver the 15th Professor Mehra Oration. This oration was started in the memory of the great legend, the iconic figure of PGI, of the department in the year 2008. And the first orator was Dr. Barbara Morazio. He's a great neurologist. Sir had a great interest in neurology, for which he got the Hari Om Ashram Innovative Award in the year 1989. And that he was the first orator. And when we had two Padma Shris, Professor Mohan Kameshwaran, Professor J.M. Hans, we had many alumni like Professor Suresh Sharma, Professor Achal Gulati, Dr. Mohan Kameshwaran, from amongst the department to have delivered this prestigious oration. Now coming to Dr. Mehra, I mean, talking about him will, I think, take a lot of time. But he was a remarkable man, and we would probably hear another alumnus of our department who would be whom we would be having listening to him in a video address just after my talk. Sir was a great clinician, I tell you. I mean, I sometimes there are certain things which you don't forget, and one of them was, we had a patient in the private room, and then we were going for rounds. Sir would, as such, never arrive beyond 8 o'clock. He would rather arrive 1 minute earlier, but never later than 8:01. And he said that private room admission was done last evening. I said, yes, sir, done. So let's go and have a look first to that patient. We went, and the moment we went to 5th floor private room, the moment the door was opened, sir took a deep breath and said, "Mainu ye na tuberculosis lagta hai, patient." He did not know anything about the patient. I had not even told him that he is presented with a little suppurative node on the left supraclavicular region, but he just said, "Mainu lagta hai tuberculosis." So I said, "Sir, this patient has this, and we have done investigations." So he said, then he looked at, you don't think it's tuberculosis? I said, "Sir, actually it's not like a cold nodule. I mean, it's appearing a little hot." So he said, "No, no." And ultimately, that his sense of smell was so strong clinically that he said, it came out to be tuberculosis. I think I had shared another anecdote, and that was his great sense of humor. And one of our former faculty members, he was actually a senior resident, and he suddenly developed interest in neurosurgery, and he wanted to do neurosurgery here. That time, a MS ENT surgeon, MS ENT could do neurosurgery. So, and he was really scared of going to Dr. Mehra and tell him that he wants to switch over to MCH neurosurgery. So he was persuaded by his batchmates and said, "Okay, why don't you go and talk?" Ultimately, he might say no. So he went and said, "Sir, I have some interest in neurosurgery and I want to do neurosurgery." So he, sir, just waited for a while and said, "If pus can go from ear to the brain, then so can you." So, so that was, Dr. Mehra, best amongst the best. He was a father of our department, such an inspiring leader he was, in spite of being head of the department, dean, PGI, medical superintendent. He would never miss a round. He will never miss an academic session. And surgeons as such, are crazy about doing surgery, so he would do surgery also. So in that, and that was our exposure to that great man. And I think most of his students would share the same sentiments as I have shared today. I am thankful to Madam Mehra. She has always been a mother figure for all of us, those we were residents. I remember we'll have most of our get-togethers would be in the PGI club. And those days, like you people, we didn't have any vehicles. We just number 11 vehicle was there. So after that, after everything was over, sir will ask, Acha, how will you go, sir? We'll just keep mum, don't say anything. Then he will say, he'll say, lady residents can come over with me. So madam and sir will go, leave the lady residents and other people in the hostels, and we would walk to our hostels back. So such affectionate lady, Madam Mehra is. So with this, I would not take much time. Thank you very much, all of you, to have come for this oration in the memory of a great person. Thank you very much.
Thank you, sir. Now we will have a video addressed by one of the PJ alumnus, Dr. Rajiv Yande, MS FRCS, who is a senior ENT surgeon practicing in Pune. So, can we have the video? Welcome, sir.
Good morning, I am
Yes,
Dr. Rajiv Yande, practicing in Pune as ENT surgeon. It has been a big honor for me to talk about Professor Y.N. Mehra, my teacher, my mentor, my guide and philosopher. I met Dr. Mehra Saab in 1977 when I joined the postgraduate institute as a junior resident in ENT. What impressed me the most was his simplicity, casualness, and his punctuality. At sharp dot 8 o'clock, many times before my arrival in the ward, Professor Mehra would be there in the ward in his long white coat, ready to receive and start the rounds in the ward of the ENT ward located on the 5th floor of the Nehru Hospital. He was an astute observer, a great clinician, and one has to be a good observer to be a good clinician as well. He knew what is happening around him, not only from the medical management point of view of the patients, but as a departmental head. He used to observe all of us. He knew all the plus and minus points of all his residents. No doubt he was a great surgeon. I would say he was a big name in otolaryngology in the whole northwest of India. He used to get patients searching for him from Jammu and Kashmir, Uttar Pradesh, Punjab, Haryana and Rajasthan as well. He was a very popular and well-known ENT surgeon. I would also specify that instead of doing lots of heroic big resection surgeries, he was a good reconstructive surgeon. Whatever he taught us about Joseph's rhinoplasty techniques, which are still followed today, probably we do more open rhinoplasties these days, but Dr. Mehra used to teach us the technique of closed rhinoplasty. He was a very good and very efficient stapes surgeon, and probably the only stapes surgeon located in the northwest of India, getting patients from all corners and from the other ENT surgeons as well. Dr. Mehra was always very enthusiastic in making the department up to date, and I distinctly remember he bought the first Zeiss microscope in PGI Chandigarh way back in 1978 when we all were residents, and it was a big novelty for all of us to use the best Zeiss microscope and the equipment for the mastoid surgery. That was not the era of endoscopic surgery anyway. But he initially taught us ear surgery by gouge and hammer with excellent dexterity. But later on, we started getting to use the drills and the microscopes. Dr. Mehra was a great administrator, no doubt. As a departmental head, he used to excel as a head of the department, keeping a good sort of congenial atmosphere in the department and being very friendly with the junior consultants, the senior residents, and all the flock of resident doctors. Dr. Mehra was a great human being, always very keen to help others, help his residents. I remember he went on long leave from PGI and joined the Maiduguri University in Nigeria in 1980. When he went there, he thought that he should have one couple of good experienced doctors from India to help him, and he wrote me a lovely letter of inviting me as a faculty at the Maiduguri University in Nigeria. However, I was committed to go to UK to pursue my fellowship and I could not join him. Later on, I met Dr. Mehra in 1990 at the Pune All India ENT conference, and later on in 2001, probably I met him last at the Postgraduate Institute Chandigarh when the PGI hosted the All India ENT conference. Today Dr. Mehra is not with us, but his fond memories will go on cherishing us forever. May God bless Dr. Mehra's pious soul. Thank you very much, my friends and colleagues.
Thank you, Dr. Rajiv. It was through the journey, and I'm sure most of us feeling nostalgic, especially those who have got the opportunity to work with them. And now I would like to request Colonel Dr. Vikas Sharma, who has been closely associated with Dr. Ajith Neelakantan and is currently head of the department ENT at Command Hospital, Eastern Command, Kolkata, and he has recently completed his MCS degree in head and neck surgery at our institute. He would introduce the orator and invite him to deliver the oration on the topic head and neck oncosurgery, the journey of the clinician. Colonel Dr. Vikas.
A very good afternoon to everyone and Jai Hind. It gives me an immense pleasure to be here on this podium today. I am here on behalf of my mentor at PGI, Professor Naresh Panda, to welcome my mentor in the Army, Lieutenant General Ajith Neelakantan, sir. Lieutenant General Ajith Neelakantan is currently the Director and Commandant, Army Hospital Research and Referral at New Delhi. The General Officer graduated from Government Medical College, Trivandrum, and then joined the Army Medical Corps in 1987. He is the first alumnus of the college to reach the rank of Lieutenant General, the highest rank in the Army Medical Corps. He completed his Masters in Otolaryngology from FMC Pune and subsequently trained at Tata Memorial Hospital, Mumbai in head and neck cancer surgery. He has been the professor and head of the Department of ENT head and neck surgery in various super specialty and Apex Hospital at the Armed Forces Medical Services, which included Command Hospital, Kolkata, Base Hospital, Delhi, in Army College of Medical Sciences and Army Hospital Research and Referral. He was also professor and head of the department at Armed Forces Medical College at Pune. He is recognized. Subsequently, he commanded a multi-speciality hospital in Pathankot and super speciality command hospital at Kolkata. He has also served as Dean of the Army Hospital R&R before taking over the current appointment. His model of keeping these hospitals fully functional during all the waves of COVID-19 pandemic has been recognized as a unique effort. He is recognized as a professor, PG examiner by MCI, NMC, and various universities, including Delhi University, Indraprastha University, Maharashtra University of Health Sciences, Rajiv Gandhi University of Health Sciences, West Bengal University of Medical Sciences, King George Medical University. He is a certified assessor and examiner for NMC and National Board for Examinations. He is a journal reviewer for Indian Journal of Otolaryngology Head Neck Surgery, Annals of Indian Academy of Otolaryngology Head Neck Surgery, and Medical Journal Armed Forces India. He has pioneered the concept of comprehensive head and neck oncosurgery capsular training, which combines clinical management protocols and cadaveric dissections for the surgical skill enhancement for PG residents, organizing regular workshops in both Delhi and Pune. He is the past president of Indian Academy of Otolaryngology Head Neck Surgery from 2017 to 18 and is currently on the Board of Governors member. He has been the National Executive Committee member and Treasurer of Foundation for Head and Neck Oncology. He has been awarded Chief of Air Staff Award for Best Published Paper in Surgery and Allied Subjects at Armed Forces Medical Research Conference in 2019 and DGFMS Award for Meritorious Armed Forces Medical Research Committee projects in 2018 and again in 2019. He has authored numerous scientific research publications in national and international medical journals and has authored 2 books, Manual of Clinical Audiology and Neonatal Hearing Screening and Manual of Head and Neck Oncology, twice in 2015 and again in 2018. The General Officer is a social golfer and takes keen interest in Carnatic music, Indian fine arts, culture and philosophy. With this, on behalf of PJMR, I would like to welcome Sir and request Sir to present the 15th YN Mehra oration. Thank you, Sir.
Jai Hind to all of you. It's a singular honor to be here on the invitation of my esteemed colleague, Dr. Naresh Panda, and be given an opportunity to speak to you. Now, I am fully aware that PGI Chandigarh is an iconic institution and it is situated right at the apex of professional advancements in the country and in the world, in fact, and to attempt to convey anything more than what is available here is a little tricky. So I was a little intelligent, so I said, let me not try to do what is not possible, but I thought, let me just share the experiences of my journey as a clinician and hopefully ignite a few constructive thoughts. In fact, Dr. Naresh told me that the audience would not just be ENT, but also would have other specialty professionals also. So that's how I would pitch it. Firstly, greetings from my hospital, the Army Hospital Referral and Research, the whole team greets you. My salutes to the stalwart about whom much has been spoken today. I personally did not have the privilege of getting associated with this iconic figure, but indirectly through my association with Dr. Naresh Panda, I think I can feel that I have established a connection which will certainly bless me. After all, one does need guidance at all times in our journey. I must acknowledge old connections with Dr. Naresh. Over the last several years, it has been an enriching association. I have always, whenever I have been with him, I come back enriched and elevated. In fact, the connection continues even now, and the fact that Dr. Vikas was here as an MCH trainee cements our connection further. And he was all praises for the tremendous professionalism and the striving for excellence, which is the hallmark of this department and, of course, of this institution. So, in fact, from the armed forces, I must acknowledge our grateful indebtedness to Dr. Naresh and the whole department and the institution for training our doctors and pointing the way to them to further strive for excellence. To come to the topic of today, I must emphasize, and I'm sure you will all agree with me, that the profession, the medical profession today is at an inflection point. There is a lot of questions being raised about the prestige and standing of the institution. There is, in the public, they are questioning some of the actions of doctors. They are suspicious sometimes as to whether the bona fides are established or not. Regulatory mechanisms, the MCA has been replaced by the NMC. Issues still have not been resolved. And more important, as a doctor, I can sense that there is a lot of confusion among the clinicians. What is the way to go? In fact, the COVID pandemic was an excellent example. I used to talk to Dr. Naresh as to how you are managing, and we used to exchange notes during that time. As I said, I was in charge of in the first wave of a multi-specialty hospital in Punjab, and I could make out how I was astonished how disoriented our clinicians were at that time. There was so much of fear. Whereas if only we had stuck to our basic training, we could have easily understood that this is a disease for which we are already fully trained to handle. So I will not, the topic is not COVID, so I will not go into it. But the fact is that there was a lot of disorientation among the clinicians at that time, and we were probably unable to take the leadership position, and we were probably led by politicians and bureaucrats rather than being led ourselves. And in that way, probably, at least partly, we let down the public also. We must acknowledge that. So my journey as a clinician, as a surgeon, as a teacher, as an academician, and in the later years as a medical administrator and as a technocrat. So certain lessons have been learned, solutions applied, the solutions lead to further lessons, and that's how it goes. So firstly, we must understand the importance of ENT as a specialty. I have always, right from the initial days, thought that this is a specialty which has evolved around areas difficult to examine and operate on. And head neck surgery, which is my field of interest, is again a complex anatomy area where other surgeons initially did not find it very attractive to enter into. So our specialty has a legacy of going in where others fear to tread, of going in to places where other people found it difficult. So that is a legacy which we have. We must be proud of it, and that should be an inspiration for us to keep marching forward. This is something the youngsters should internalize, and it will be good if they do that. We are also, as a specialty, remarkable in the sense that we have focused on a quintessentially Indian problem of head and neck cancers, and over the years has somehow, to some extent at least, achieved a leadership position. We know the nature of the problem, we identified it. The population-based cancer registries have identified that these are predominant cancers in our cities. The practice of ENT and head neck surgery as a specialty has taught all of us the importance of handling a multidisciplinary canvas. As you can see, we have to straddle all these different aspects to fully and effectively practice our specialty and handle all these aspects of the profession. And we have been able to some extent at least, train our youngsters in this comprehensive manner, and this is the way we have to further focus on, and that is the way we will achieve good results. So this is a lesson that we must understand, that the more you broaden your canvas and the more you collaborate with other specialties, the enrichment which will come into our specialty will be of further immense benefit to all concerned. For example, oncologic anatomy. Now, this is different from descriptive anatomy, which we were taught earlier, or even the surgical anatomy, which we were taught probably in the earlier years of surgical training. Oncologic anatomy is very important for staging, and it is so essential that we internalize it and practice it precisely, taking into account the precise definitions of what is oral tongue, what is lip, what is mucosal lip. So like that, it's a different perspective altogether, and that is the discipline we must bring into the practice of our profession. Similarly, when we deal in head neck surgery with the issues relating to carcinogenesis, the concept of cancer as a systemic disease, the concept of surrogate markers, and a very good grasp of possible paraneoplastic syndromes is very essential to keep in mind if you have to handle our patients comprehensively and address all issues in a correct manner. I must emphasize here that it's so important for us as a clinician to understand that cancer is not a black and white diagnosis. It's a spectrum. It's a spectrum of changes which occur in the tissues, and we must understand that the pathologist also has to deal with this spectrum, and the reports which they generate has to be understood in this context. It is erroneous on our part as clinicians to expect pathologists to give black and white diagnosis each and every time. That will not happen. And that's a lesson which I have learned as a head neck onco practitioner, and which I must share with you. The importance of synoptic reporting as a discipline. Some institutions I have seen are doing it, but there are so many institutions in the country, or so many pathologists and cancer centers where even today synoptic formatted reporting of histopathology specimens is not being done. This is something which we have to insist upon as clinicians, and then only we can train our youngsters to insist on it, propagate it, and get it done, and then only we will march forward in an appropriate manner. Take, for example, the issues of margins. Now, again, some report margin positive, negative. That's not where it ends. We must understand very clearly what is radial margin, what is shave margin, because this, unless you understand this and collaborate with the pathologist, we will not get correct reporting. The concept of adequate margin has been flogged immensely over the years. Still, when you go to any conference or a meeting, there's a lot of confusion about it. We will understand all these things if you understand the molecular basis of it, and also the limitations of this margin reporting in terms of the sampling error, the orientation error. There are skip lesions which can vitiate the whole report. And also, we must understand that deep and soft tissue margins are very difficult to accurately report on by any pathologist, and therefore the clinician has to exercise his discretion in interpreting all these reports. I'm sure the audience here will understand the intricacies of these issues. But suffice it to say that margin reporting is a very difficult area, and clinician and the pathologists have to collaborate to arrive at a reasonable conclusion. Again, the bottom line is that we as clinicians should be brave enough and confident enough to say the last word in these matters. We can't abdicate our responsibility to the pathologist. shrinkage. The tumor margin, the margin shrinks, the size shrinks. We have seen it per op. What is the size? That is the correct measurement. And we should be confident enough to note it down and proceed further. We must be aware of the post-RT artifacts, the laser artifacts, and the observer bias, sampling error in the reporting of the gross specimens, and also what is the level of scrutiny, how many slides, were things missed. So all these things we have to understand. The reason I'm emphasizing is that over the years I've seen that a lot of clinicians just go by the written report as if it's the word of God. It is not so. In fact, if anybody is a God, it is the clinician here. We are the last word. And once we have that conviction, we will be better off. So, again, an image in the coming after pathology, that is the imaging. Again, there are limitations of the radiology and radiologists. In the early part of my career, I found a lot of radiologists were very, very tentative in their understanding of head neck anatomy, temporal bone, neck, and their reporting was very suboptimal, at least some of them at least. Things have improved over the years, but still we are still having to scrutinize the images ourselves, and that's the best way to go about it. Of course, when we interact, we can enrich each other. Specific techniques like the puff cheek techniques or using a bite to delineate the oral cavity are simple measures which can improve things. And even in all this also, the clinician has to ride and guide the radiologists. Now, this is the sclerotic thyroid cartilage, which is described as one of the earliest signs of cartilage involvement in CA larynx. Cartilage involvement in CA larynx, such a crucial factor in deciding the staging and further management, is still fraught with difficulties and uncertainties, and there is no point passing the buck to the radiologist. You have to take the stand. And in fact, I remember one of my earlier cases many years ago. There was a patient who was repeatedly biopsy negative on CA larynx, and I said, let us go ahead and do total laryngectomy. And so many friends came and told me, don't do this. This is very dangerous, especially in the early part of your career. I said, no, I'm a clinician. This is my judgment call. And we proceeded, and sure enough, in the histopathology, it was cancer. So I felt validated as a clinician that I not only took a judgment, went by it, and was proved right. This is how a clinician improves. You have to constantly commit on your judgment, and as you get it right, you go along that track. If you get it wrong, you audit yourself and see where you are good. And a good clinician ultimately is a man or a woman who gets his judgment right most of the time. Same thing with post-RT issues also in head neck malignancies. Nodal Metz criteria. Again, the criteria which are laid down for imaging criteria for neck modes are based on statistical analysis. In an individual patient, that may not be enough. In fact, I would like to stress to the audience here, especially the youngsters, imaging in head neck in any disease is not a cartography exercise. It's not about mapping the area. It is about questions that need answers, and we must be able at the end of it to be clear about the question and also get the answers. If the radiologist cannot give it absolutely, we have to take a judgment call, but some answer has to be there to proceed further. Again, as I said, the last word is with the clinician. There is no escaping the fact. The challenge of endoscopy, we are all aware, and constantly, the technology has been helping us, and it has been a wonderful journey as far as endoscopic imaging and endoscopic surgery. The progress has been tremendous, and I'm sure there are exciting times ahead with the further improvement in technology and technical assistance. Issues like new parameters, the clinicians have been able to identify and successfully implement in patient care, like oral tongue, depth of invasion, which has now come into the decision-making process. The multidisciplinary team, I have already alluded to how we ENT head neck surgeons have been able to very successfully integrate into a multidisciplinary functioning mode, and probably we are a good role model on multidisciplinary care, which other specialties can, to some extent, from us, I feel. That is a good thing which we have done. Because many a time, the decision making is questioned by the patients and the next of kin, because they're not sure whether we exercised due diligence and all that. So the tumor board concept and all are wonderful mechanisms which even today some of the other disciplines in medicine probably can learn from these disciplines. Again, the emphasis on clinical practice guidelines, which head neck oncologists and oncologists in general have been able to institutionalize, is probably lacking in some of the disciplines. Even, I would dare to say, in this forum, otologists probably can, those who concentrate on otology in India can probably take some lessons from the head neck stream as to how to practice as on the basis of duly recognized practice guidelines. Of course, we must understand that these guidelines have got their limitations. For example, most of the oncology practice guidelines are based on the 20% cutoff. That is, if the probability is less than 20%, we do not act. But 20% is a big figure, 1 in 5. In a particular case, we may not be happy to go by the 20% and leave out 1 out of 5. So we are perfectly justified in going beyond that in an individual case if that is our judgment. This is something which a lot of youngsters are getting disoriented about. Remember, 20% is a very big figure, and we are well justified to go beyond that. Another thing which I constantly bother about as a teacher, as an academician, too many classifications, too many gradings. Everybody wants to bring in a grading, and recently, and some of these recent gradings, they run into, in a particular parameter, there are 20 classifications, 20 sub-parameters. Just look at TNM, 3 parameters and 4. That we cannot handle. So imagine a parameter where there are 5, 10, 15. It's impossible. I do not understand what is the point. It just then becomes just a descriptive shorthand, not a real classification which we can handle for any other purpose other than description. So this is something we must be careful about. I tell my students, please don't get into too many classifications, but then some of the teachers then force them to do it and they evaluate, so that's a problem. So we seniors should introspect on this matter. Classification is not shorthand or short forms. Just a word about how to adapt to local needs. In my own practice, I did a lot of partial laryngectomies, open partial, which I found was wonderful, especially in supraglottic carcinoma small, where you do a supraglottic laryngectomy with wonderful results. But there's a lot of reluctance to do it because radiotherapy is easily available. But if you understand the dynamics of particular situations and the way the patient, the area and these conditions, probably I feel there's a scope for more surgery in this matter. And this has been my conviction. Anyway, we must adapt to what is required. Of course, pediatric oncology is a field where ENT surgeons are good with children, so that's okay. Staging, we have to a large extent understood the principles of cancer staging and used it purposefully. I think the youngsters would do well to memorize a few things. If nothing else, it will improve their dendritic arborization and prevent the onset of senile dementia in your later age. Do it. It's better. So, yeah, so there's no need to go into all the way and know this. But again, yeah, I will emphasize on pathological staging. Too many mistakes due to shrinkage. So my practice has always been that I always document my intra-op measurement, and I've never hesitated to overrule the pathologist and put down the P stage as per my per-op measurement. And no tumor board has ever questioned me on this. Because I have not been reluctant to sign there. We all know still we know the limitations of staging, and this is where, as I said, we have to go beyond practice guidelines and bring in these inputs from our understanding as a clinician. These are all, I think, very obvious things. Yeah. This seems important that if all else is the same, then we have to consider issues like competence, cost, convenience, compliance, and complications when we take our decision making. Again, this is what the clinician has to do. Again, same message. All decisions, we must tailor it to specific situations. That is our job. That is where our expertise, our experience, and our skills and knowledge come into play. The only point I want to make is that cosmetic surgery, probably because of the fact that I was interested in oncology, I always had a question: how much, in a setting of limited resources, how much emphasis we can give to cosmetic surgery, say rhinoplasty in our specialty. My experience was that in a government hospital with so many demands, I always felt that rhinoplasty was a luxury I couldn't afford unless it's a functional rhinoplasty, not cosmetic. So I used to discourage, but I'm sure there is a possibility of variation of opinion on this matter. But the point is that we must cut the cloth as per availability and not be defensive about it. Too many surgeons get disoriented about fitness for surgery, and too many anesthesiologists unnecessarily take the blame. This is what I've seen in many hospitals. They say, no, he's not fit for surgery. You have to just say, what is the risk? It is the clinician who will decide whether this risk is worth the expected outcome. So at least, so now in our hospital, we are strictly following this, that the anesthetist does not refuse anything. He will say, you want to operate today? This is the risk. Surgeon has to take the call. Reconstructive surgery, so much of development. There's been exciting field, exciting journey. In fact, there was a time when fibula would make it to Indian Express. So with photograph, things have changed now. This was from AFMC many, many years ago. But that's how it is. Radiotherapy has again been an exciting journey, so much of development. The only thing I could not understand today is why this reluctance to do altered fractionation and substitute it with chemotherapy concurrent. This is something I think we must press forward as leaders and seniors to find a better solution adapted to Indian needs. We should be doing more altered fractionation. That's the bottom line. We are not doing it. Chemotherapy, again, I think we all know the issues with chemotherapy in head neck. How much to do? Nobody has a clear answer. And every hospital, even today as a commandant of Army Hospital, I am faced the issue, how much of budget to give for the costly chemotherapy drugs which do not achieve much. So it's a very difficult problem. follow-up protocols, of course, has to be documented, and we have been able to have a good disciplined approach to follow-up in head neck oncology. Rehabilitation, again, we have considerably gone further from the old emphasis on esophageal speech and all that, which is not something which we should even bother about, I think, today, if you ask me. That's my judgment. We have to just go for better mess, and it's very easily available now. This is, again, another area where the clinician has to come into its own. A disease already proved. For recurrence, you don't have to keep on proving it. There are problems in proving it. As I said, it's a spectrum, and with artifacts post-RT, it's difficult for the pathologist. You can't just pass the buck to the pathologist and say that he has not given me a report. It's an already diagnosed disease. So we should go forward and use our judgment. And of course, we should know when to stop. Because palliative care is a big issue, and in head neck oncology, as in all oncology fields, and of course other disciplines also, the use of palliative care and its when to start and when to stop trying to cure are issues which the clinician has to take a call on, and this is something where I feel there is a scope for improvement. We know what is to be done. We know the issues of cancer care. We know the problems of pain management especially. But we need to be very clear when to ease up. This is something which again bothers me. Even today in any hospital, including my hospital, there are patients in the ICU who do not deserve to be there. And a lot of resources are wasted. Not only that, a lot of wrong practices come in. A terminal case, a terminal care patient who is ventilated develops ventilation-associated pneumonia. There is a tendency to start antimicrobials, antifungals, antiviral. What does it achieve? It achieves only a generation of more resistance. So these are issues. Unnecessary code blues and resuscitation is another issue which we tend to sometimes overlook, but certainly not a scientific approach. This is not to be, and many people confuse these issues with euthanasia. No, this is not about euthanasia at all. So this is an issue, this is an area where we need to be a little more scientific and practical. In my experience, not once when I have spoken to an NOK about these issues has anybody ever disagreed with me that we should ease up. Not once. In fact, they were waiting for me to put this into words because they cannot say it. And in fact, when I say it, they thank me profusely. This is my experience. But I still find a lot of people reluctant to take it on. It just takes 5-10 minutes. That's all. In the Indian context, you don't need half an hour for it. It takes 5-10 minutes. That's all. And when the thanks come, it's really gratifying. So we should not prolong the act of dying. It's related to this. In cancer, people confuse counseling with being an informer, soother, comforter, concert. No, we are supposed to be a learned guide. There's no point saying, I've told the patient to make the choice. He doesn't have the wherewithal to make the choice. We have to guide him. It's a very lazy approach to say that I've told the patient, "Aap batao kya karna." How can he tell? How can she tell? We have to guide. Death certification, huge problems. I think COVID brought it out. When the West Bengal Chief Minister said that there is no COVID, there are very few COVID deaths, people jumped. But there was a kernel of truth in what was said that, when you have a pre-existing disease and then there's a terminal pneumonia which sets in, which is a normal turn of events in a lot of advanced diseases of various kinds, what is the cause of death? It's a dilemma. It's not so easy to say that it is this or that. But fundamental thing is that we must basically say that it is, as a clinician, I would say if a cancer patient, if a head and neck cancer patient dies of aspiration pneumonia, the cause of death is carcinoma larynx, not aspiration pneumonia. You can add it as an additional diagnosis, but the fundamental, this is a mistake which a lot of people are still doing. Therapeutic illusion, I think a lot of us who deal in cancer should be aware that many a time there is an illusion that we are achieving something. It's better we understand that. Survival rates. The only thing I am always worried is that term called progression-free survival, with a lot of medical oncologists are very fond of. It's a deadly parameter. Progression-free. People, I mean, the disease is still there. So, general outcomes, I think we all are aware that it's very difficult to improve outcomes in general. Screening, I would just like to say that screening is a very tricky issue, and we are not really advanced very much, at least in head and neck cancer as far as screening is concerned. Probably we can see what can be done. But certainly raw data collection, these are the old, handwritten data cards which we used to have in our departments very many years ago. At least the raw data is collected. Research, of course, oncologic research, very good. Lot of work is being done. But only thing in surgical specialties, we must understand the limits of publication and be non-defensive about it. We can't say that because we are not blinded it, it's a low quality. Let's not get too defensive about it. This is a surgical specialty. And sometimes we follow prey to the tyranny of data, which we should avoid. What is obvious, and we should be able to state the fact as a clinician. In fact, if you go further philosophically, I think a lot of our problem with the public is that intellectual property right is actually a Western concept. It is not ingrained in the Indian gene. Our artists, our scientists never monetized knowledge. Saraswati and Lakshmi were not supposed to be compatible with each other. This is in our genes. Now, but the Western concept is that knowledge is to be monetized. This is the problem, and that is why when we, being influenced by Western concept, try to monetize it, the public resents it, because we are inherently unhappy with monetizing knowledge. I think we should start to understand this. I have started to understand this. In fact, that is why when Vikas was saying, I emailed him this presentation. I said, there are no videos in it. He said, no, but should I delete it after that? I said, I'm least bothered whether you delete it or not. I've always shared all my slides to whoever wants to take it. It doesn't belong to me. This knowledge was gained over the years from various agencies. So anything you can share. Research potential, I must share with one approach which we must understand, that question things which doesn't seem good. Many years ago, I was sitting in a multidisciplinary forum in a hospital, and one cardiologist stood up. It was the discussion was on cardiology. He said, all nuts are good except coconut. Now, I am from Kerala. I was very hurt. It was a patriotic attack on us. How can coconut be bad? I said, we have been eating and drinking coconut for generations, for centuries. And Kerala is a very densely populated state. If it was so bad, it would have been we would have all died out. Yeah, obviously, it did not. And I was proved right. 20 years later, the cardiologists changed their minds. Now, coconut oil, people are drinking coconut oil. No Keralite ever drinks coconut oil in a spoon. We add it to our dishes, but we never take it like that. So, we overlook the obvious that if something has been there for centuries, it cannot be bad. And it has been accepted by trial and error by generations. Similarly, coming to our head and neck oncology, I have not understood tambulam and this betel nut and this supari. It is a it is given as an auspicious item in all rituals. If that is the case, how can it be a carcinogenic? I have my doubts. So it is and in fact, we have recently trying to make out a protocol. I always wanted to do this. Is it that the addition of betel leaf and lime or something, does it change the dynamics? There has to be something. It cannot be otherwise. A totally addictive, harmful thing cannot have been part of a ritualistic, auspicious practice for centuries. It would have been, somebody would have found it out. So this is the way we must question things. No point saying, no, we were like that, everything we did was bad. That's a wrong approach. We must question it. So community outreach. This is this is just a photograph of a debate in AFMC between undergraduates and postgraduates, where we discussed about how doctors are perceived by the public. So we have the practice of, I'll skip all, there's nothing much to say. Only thing that I'm so glad that ENT has evolved with a lot of MCH courses being conducted. I would just say that I feel that the future is integrated ENT practice, where a group of people with different capabilities get together. In big institutions it's being done, but I look forward to seeing it in more institutions. The importance of teaching department. This is a responsibility which over years you must, as you grow senior, you must learn to be responsible and don't blame juniors. Training. The cadaver dissection, all good institutes are doing it. That's a great advancement in our specialty. These were the earlier ones. A lot of stalwarts. We always get stalwarts in our institutions. The scientific temper. This is something which I want to emphasize to the clinicians, the youngsters, that clinical discipline. Do the best to each patient at all times. And this is a quote from the Viveka Chudamani, Konama Bantha Kathama. In fact, he asked the question, what is this thing? How has it come? How is it established? How to get rid of it? What is it and what is not? The differential diagnosis, the etiology, everything is in that one shloka. So the approach, I just want to say that the approach to knowledge is the same, whether it is medicine or any other subject. The whole thing has to be understood in its entirety. And you must always be desperate to learn. And the teacher should always show the way without any hesitation. And our forefathers talked about two principles. Either it is Markata Nyaya or Marjala Nyaya. That is, the monkey baby clings, whereas the kitten has to be lifted. The student should be like the monkey. He should cling to the teacher and not let go. And Arundhati Nyaya, of course, from a known to the unknown, from the branch of the tree to the big star, from the big star to the less bright star, and there finally to Arundhati, which is a very faint star. So you cannot see it directly. So to show it, you have to go from what is known, less known, less known. So these are principles which are applicable everywhere, and as teachers we should know this. So to sum up, it has been a fruitful journey, and there are the way stations were many. I know there's no end. We must keep going. And I would just say that seniors in any profession, and this is my firm conviction, should not get too engrossed in minutiae. They should look at the broad perspective, and that is when they will really perform their leadership role. And as in all endeavors of human activity, a philosophical underpinning will greatly enrich matters. So I happy training and testing, that is researching, to all of you. Once again, I have just tried to share a few thoughts in a conceptual manner in my journey as a clinician, especially focusing on head neck oncology. And it's been a privilege to have an audience like this with so many stalwarts and seniors in front of me. My best wishes to all of you. Jai Hind.
Thank you, Lieutenant General Dr. Ajith Neelakantan. You made such a complex topic of management of cancer so interesting, and I'm sure uh, the residents and professionals of different stages who are present here benefited one and all. Thank you so much, sir. So now I would like to request Professor Dr. Naresh Panda sir and Dr. R.K. Rathod sir, Sub-Dean Research, to do the honors of presenting the memento and the scroll to Lieutenant General Dr. Ajith Neelakantan. May I request Professor Jayamanti Bakshi, Professor and Head Unit 2, Department of Otolaryngology ENT, and Dr. Rijunita to kindly assist. May I request Professor Ramandeep Virk and Professor Sandeep Bansal to assist in presenting this group. Thank you, everyone. And I would like to request everyone to join us for. Sorry. My apologies, Professor Rathod sir. May I request Professor Rathod sir to address a vote of thanks.
A very good afternoon. What a oration. Whole hall, they are mesmerized. Not a single moment a person could afford to lose it. Full with science, mythology, spirituality, conventions, public practice, day-to-day practice, all together into oration. Absolutely. Thank you, sir. Thank you very much. Lieutenant General, Professor Ajith Neelakantan, if I properly pronounce the name, I think the Director and Commandant of Army Hospital, RR, New Delhi, Professor Naresh Panda, the Dean Academic and Head of Otolaryngology, Head and Neck Surgery, PGI Chandigarh, all my former deans, emeritus professors, former professors and head, all the senior colleagues, the registrar of PGI Chandigarh, and of course, Ma'am Mehra. So we are so fortunate to have you here. All my faculty members, students, and researchers. I feel privileged to be here to extend a sincere gratitude to Lieutenant General Professor Ajith Neelakantan for accepting our request out of his busy schedule to be a part of our extended family and a orator of such a prestigious Professor Y.N. Mehra Oration. So we feel privileged and feel proud of you, sir. Also, your sense, wisdom of knowledge, whatever you have said, and also your professional experience all together would be really useful to all of us, including junior and senior people in clinical science. To express our thoughts, I would like to say that we the faculty or fraternity of PJ are much more fascinated to be associated with those who have been serving the armed forces as a matter of pride and prestige. So thank you, sir. You have been here, so we feel so happy to. Further going to have, we express our sincere gratitude to Ma'am Mehra and their family members who have been helpful to the department to institute such a important oration in our institute, and which is going on since so many years, starting from I think 2005 or something 6. So every year it is going successfully. It's a very great achievement for the institute. I lastly thank to the PGI administration, the telemedicine, then the Department of the Otolaryngology, Head and Neck Surgery, the faculty and the organizing team, taking so much of time to organize this oration in such a way so that it ended with such a beautiful and useful manner. So thank you all for being here. Thank you.
Thank you, sir. Now, can I request everyone to join us for high tea?